Ohio, and it's a pleasure to talk to you today about MCHAT and autism screening. In thinking about screening for autism, it's important to consider some of the basic facts about autism. I know some of you listening have a lot of information, a lot of expertise in autism, and others maybe not so much. But when we're thinking about screening for autism, it's important that the people we're asking to screen, primary care physicians, therapists, child care providers, whoever they may be, it's important to make sure that they understand the basics about autism, because it will help in how they screen as well as emphasize the importance of screening. Autism spectrum disorder is a neurobehavioral disorder characterized by persistent deficits in social communication and repetitive restricted behaviors that occur across multiple settings. We diagnose autism using criteria from the DSM-5, the Diagnostic and Statistical Manual, 5th edition of the American Psychological Association. The importance of that related to screening is that we use behavioral criteria. I'm going to say this a few times, so bear with me, but we do not have biomarkers for autism. We don't have an imaging study, and we don't have blood or urine tests that we can do, which makes the need for developmental screening that much more, but it also makes developmental screening and even diagnosis of autism very complex. These are the criteria set forth by the DSM-5 for autism spectrum disorder. I'm not going to go into them in great detail, except to note that children need to show deficits in all 3 areas of communication and interaction: social emotional reciprocity, nonverbal communication, and in relationships, and then have at least 2 of the behavioral criteria. These include repetitive movements or speech, such as echolalia, inflexibility, rituals, restricted interests, or sensory issues. There are some very nice examples of some of these behaviors and characteristics on the Autism Speaks website. One other thing to note is that there is no behavior that is pathognomonic, no behavior that's specific only to autism. And likewise, there's no behavior that if you see rules out autism. Lots of people think about autism and lack of eye contact, but you can see lack of eye contact in kids who don't have autism for other reasons. And you can also see kids with autism who have fairly good eye contact, but have other deficits in nonverbal communication. So that makes the diagnosis very complex, and it also, again, makes the need for screening that much greater. Most of you are aware that the prevalence of autism has been steadily rising over the past 30 years. In 1985, the prevalence was estimated to be 1 in 2,500, and this graphic shows it 1 in 110, and this is actually outdated a little bit. It's now estimated to be 1 in 68. A lot has happened over the past 30 years. The diagnostic criteria for autism in the DSM has changed 3 times, and our conceptualization of autism has changed. The view back in the 70s and 80s was a very narrow view of autism, more along what used to be called cancer autism, the most severely affected children. And that has, over the past 30 years, evolved significantly. So that's one factor. Another factor is that there's some evidence that the prevalence studies done back in the 70s and 80s had very different methodology than the prevalence studies that we're doing today. So it's a little bit of comparing apples and oranges. So the reason for this rise in prevalence is most likely multifactorial, and we certainly don't have all the answers about why the prevalence is increasing. One of the things we do know is that the co-occurrence of certain conditions is changing as well, the biggest one of this being intellectual disability. So even over the past 15 years, you can see the difference in the co-occurrence of intellectual disability with autism. Back in the early 2000s, nearly half of the kids diagnosed with an autism spectrum disorder had a co-occurring intellectual disability, or what used to be termed mental retardation, whereas the latest figures show that to be slightly less than 1/3 of children with autism are diagnosed with an intellectual disability. The largest growth in prevalence has been in these children without a coexisting intellectual disability. So in many ways, the landscape, the face of autism has changed significantly. That has implications for screening and early detection as well. If providers of whatever discipline are considering looking for signs of severe developmental delay as an indication that the child might have autism, the fact that only a third of the kids with autism have intellectual disabilities suggests that many children with autism are going to present without those very significant severe delays as their first early sign. So we have to be looking at other things as well. The current statistics tell us that 1 in 68 children have autism spectrum disorder. The male-female ratio remains around 4 to 1. That hasn't changed much over the last 20 years or so. The other thing that is not changing as rapidly as we would like either is the median age of diagnosis. That remains around 4.5 years of age, according to the latest CDC studies, despite the fact that the parents report being concerned much earlier. Many parents report being concerned by the time the child is 12 to 18 months of age, often because of language delay, but also for other things, social withdrawal, lack of eye contact, for instance. But what tends to happen all too often is that they are either given false reassurance, there's not any screening done, and they don't end up getting referred for evaluation in a timely manner. The other thing that happens, unfortunately, is that we have huge access problems for evaluation, and so children can wait on wait lists for a very long time before getting diagnosed. So unfortunately, many children are not diagnosed as early as they could be, and they lose some valuable time during which early intervention would make a big difference. That illustrates the need for screening all the more. The other thing that it's important to realize is that there are risk factors that should make providers, no matter what you're seeing the child for, a little bit more suspicious and have a lower threshold for being concerned about autism. These are associations, and there's a wide range of them. Advanced paternal or maternal age has been associated with an increased risk. There was one study recently with showing that young teenage moms also had an increased risk. Low parent level of education is seems to be an independent risk. Some studies have suggested that in vitro fertilization, that those kids had an increased risk of developing an autism spectrum disorder. I already mentioned male gender. We don't know why males are more susceptible to an autism spectrum disorder. And then siblings with autism spectrum disorder is a huge risk factor. Some studies suggest 18 to 20% recurrence risk if you have one child with autism. So it's very important that providers who are seeing children who have a sibling with autism have a very low threshold for considering could what I'm seeing with this child be an autism spectrum disorder. Low birth weight and preterm delivery are other risk factors as well. Maternal smoking seems to be a risk factor for all kinds of developmental issues, and it's just never a good thing. And then there are specific genetic conditions that are associated with higher than typical rates of autism. These are some of the genetic conditions. Despite the fact that we know genetics are involved, we most of the time cannot find a specific genetic cause. We know that genetics are involved because siblings have a higher risk. Identical twins have a much higher risk, a 60 to 90% risk of having a development of autism spectrum disorder, or at least some sort of developmental issue. But we most of the time cannot find a specific genetic cause. There has literally been an association of a disorder on every single chromosome that's been found to be linked with autism. But there are some chromosomes that are more likely to find abnormalities associated with autism, and some of them are listed here. There are also specific conditions such as Fragile X, tuberous sclerosis, for instance, that have higher rates of autism than the general population. However, most of the children with those conditions do not have autism, and those conditions only account for very small single-digit percentages of the children with autism. I remember when when the diagnostic test for Fragile X was first being developed, the DNA test, and we were sure that it was going to identify at least a sizable minority of kids with autism, and it really didn't. So there's a lot that we don't know about the genetics of autism thus far, but the presence of these conditions should make people more suspicious and be looking more closely at these children because they're at higher risk. What we do know is that there are differences in brain functioning in children and adults with autism spectrum disorder. We know that there's decreased functioning of the social brain nodes, which are spread out throughout the brain, and that there's abnormal activation patterns, including language processing lateralization. Generally, one of the more widely accepted theories is that this is an issue of decreased connectivity through different areas of the brain, and that the mirror neurons, the neurons that fire when you see somebody, for instance, waving their hand, the neurons in your brain that map to your hand fire even though you're not making any movement. Those are the types of things that have been shown to be involved in autism. The tricky thing, however, is that there is no specific pattern that's been found to be widespread enough to allow us to do even functional studies on children diagnostically to help us figure out which kids have autism. So there's a lot of this work still in progress, but unfortunately it doesn't at this point in time help us really determine which children are likely to have autism. So the bottom line is that we, for the most part, don't have a definitive cause in most cases of autism. And again, there are no biomarkers. There's no imaging study. There's no functional MRI study that's likely to be helpful, and no biological markers that we can test for. So we're back to the point of really needing to do good developmental screening. To address that, the American Academy of Pediatrics in 2006 issued guidelines about developmental screening, including autism. Oops, for some reason my slides are, there we go. Sorry about that. So the AAP in 2006 issued a statement, a guideline statement about general and autism-specific developmental screening. They recommended using parent report measures at 9, 18, and 24 months for general developmental screening, and using an autism-specific screening tool, parent report again, at 18 and 24 months. Other agencies, organizations have endorsed these guidelines as well. The CDC's Learn the Signs, Act Early campaign encourages the same, following these same guidelines. Bright Futures also encourages the same guidelines. And then Healthy People 2020 not only recommends this type of screening, but also has the goal of increasing the percent diagnosed by 36 months of age. The AAP 2006 statement was reaffirmed in 2013 without changes, so this is still the current guideline. All right, so we are 9 years into this recommendation with developmental screening. Where are we at? Well, the research is not terribly encouraging about how developmental screening is actually being done. The National Children's Health Survey, most recent one, asked parents of children young enough to have developmental screening done, did your physician ever do developmental screening? And not quite 20% of them said yes. Now, pediatricians in a separate study reported better use of developmental screening. About not quite half, 47%, said that they used a standardized tool for developmental screening. So they were reporting more use, but still 9 years into development of these recommendations, not only half of them are reporting that they do it. So what's the issue here? Well, one thing that's been speculated is that for parents, they may not recognize that the child's actually had developmental screening. Parents fill out a lot of forms in the physician office. They may not have noticed that this was a particular screening tool. That does suggest, however, that those results weren't reviewed with the family, at least in a way that they remembered. From a physician's point of view, many physicians rely heavily on clinical judgment. I had a physician recently say to me, I do the screening, and I applauded him for that, but it never shows anything that's a surprise to me. It always just validates what I thought. I said, well, that's great, and I congratulated him on his clinical acumen. However, research shows that clinical judgment alone only detects about 30% of the children with a developmental concern. Now, that's developmental concern in general, not just autism. But it illustrates the point that clinical judgment alone is not sufficient to detect most of the children who need further evaluation. Some physicians don't trust parent report measures, which are really the tools that we have available for optimal in-office screening. And there are probably particular times or populations that it's very difficult to get reliable reporting on. But in general, the parent report measures have been shown to be very accurate. That parents really do understand the questions and in these standardized tools and do report very reliably their concerns or about their child's development. Some physicians are using informal checklists instead of a standardized tool. These are oftentimes developmental milestones that have been perhaps pulled from a developmental tool, from a standardized tool. But they're using them as just sort of a list and having parents maybe check them off or answer them as a question in the office. The issue with the informal checklist is that research has demonstrated that they're no more reliable than clinical judgment, because even if they came from standardized tools, they are not being used in the standardized way, and so it becomes clinical judgment about what do you do if the child does everything except one item, whereas with using a standardized parent report measure, there are guidelines about the failure of certain items or number of items that can help guide what you do next. Time and reimbursement factors are often mentioned as a reason for not doing developmental screening. It does take more time to do that, so practices and practitioners need to consider where that will fit in their workflow. It's important to note that other staff, nurses, receptionists, office staff can be used to help distribute the developmental screening tool, help score it. So it doesn't have to all be the physician who is having to do all of it. There are reimbursement codes for physicians to do developmental screening. So there is the possibility of reimbursement. The MCHAT, which is specific for autism screening, is available free online, so there's no cost to obtaining it. The other developmental screening tools for general development, there is a cost involved, but as I mentioned, there are reimbursement. There is some reimbursement for physicians to be able to do this screening. This is the CDC's recommendations for developmental screening. I'm not going to go through it in detail, but except to note one thing, which is at the bottom, that if there are further concerns, there are arrows pointing down to what to do next. And one of those is, if the screen is positive, to make appropriate referrals for both diagnostic evaluation as well as for early intervention services. You know, I want to emphasize that because screening is not enough, and screening doesn't do much if you don't do something with it. And that may sound very self-explanatory and very basic, but there have been some studies that showed even with a positive screen, children were not getting referrals. And there were a variety of reasons mentioned in some of those studies, including lack of resources in the community, which can be a very significant issue. although there are birth to 3 services that are available, that are mandatorily available in every state. But sometimes it's also a matter of providers not really knowing what's available in their area, so they do the screen but then don't know quite what to do with it. The other thing that unfortunately happens is that some people do the screen but then treat it like clinical judgment anyway. I just had this conversation with a subspecialty clinic that sees some kids with that are at high risk for autism, and a provider of services there was mentioning that they do the MCHAT but never refer kids that they don't otherwise have developmental concerns about. And we talked a little bit about the fact that that's very non-standard use of the screening tool, because the whole point of the screening tool is to identify kids that you don't have clinical concerns about. So there are many different ways that screening can go awry, unfortunately. Right. Regardless of what the screening shows, providers should be on alert for some red flags. And this includes things like not babbling or pointing by 12 months of age, by 2 years of age not having 2-word combinations, or developmental regression at any time. Some of those are not specific necessarily for autism, although regression is something that we see in 1/4 to 1/3 of kids, but should make you think about, does this child have a developmental concern going on, and what should I do next? So some of the screening tools that are used for general development, where the 2 most popular ones are the ages and stages, the ASQ, or the PEDS, which is the Parent Evaluation of Developmental Status. The PEDS is a more general questions. They are carefully worded but open-ended questions about any concerns about different domains of development, while the ages and stages questionnaires, there are different ones for different ages, and they have specific questions about, does your child do this, this, and this. Autism-specific screening, the most commonly used one by far, is the MCHAT, and so I'm going to talk a little bit more about that. The MCHAT is an autism-specific screening tool designed to be used for children 16 to 30 months. The revised version has 20 items and a follow-up interview. It has pretty good sensitivity and specificity. I went back and looked at the article about the revised MCHAT to say, really, is this what they're listing as sensitivity and specificity? And it was really this good. And then positive predictive value for any developmental concern is 0.94. That caveat, any developmental concern, is important, because the other thing that we often see is that people are using the MCHAT as their only developmental screener because it's available free and online. And it's not designed to be used like that, but what happens is that a child with a developmental delay may screen positive on the MCHAT simply on the basis of the developmental delay. So if you're only using the MCHAT, you have to be kind of cautious about how you interpret a positive screen. There was a previous version of the MCHAT that some people may be familiar with, so I'm just going to highlight the differences. The revised version has been out for about a little bit over a year, maybe a year and a half now. It has 20 items compared to 23 items on the previous version. The previous version had 5 critical items, and so the scoring was a little bit more complicated about how many critical items you failed or how many total items. With the previous version, if you failed between 3 and 7 items, it was recommended that you do the follow-up interview. And I should note that the follow-up interview is important, because the sensitivity and specificity that I mentioned only occurs if you use the follow-up interview at the times that it's recommended. So for this revised version, the scoring is low, medium, and high risk. Low risk is failing 2 or fewer items. Medium risk is at 3 to 7 fail, and then high risk is greater than 7. So this is what the scoring algorithm looks like. If you score less than 3 items, no further follow-up needed unless surveillance or something else suggests it. Again, that would be a time to really be cautious for those high-risk groups of kids, even if they don't fail the MCHAT, to make sure that you're following them closely. A total score between 3 and 7 those are the kids that need the follow-up interview administered. And the follow-up interview consists of specific clarifying questions based on which items the child failed. So you don't have to administer 20 interview items. You just administer the ones that the child failed. The follow-up interview is available online. It can be administered by a clinician or by an office staff member. And then if the follow-up, based on the follow-up interview, if they fail more than 2 items, then they should be referred on. So if they have a total score of 8 or more failed right off the bat, then you don't even need to do the follow-up interview. You can refer immediately for diagnostic evaluation and early intervention services. Again, another important thing to note is that diagnostic evaluations can take a while. There can be waiting lists. It can take a while to get in. And it's important to refer for intervention. Birth to 3 services, which are called Help Me Grow in the state of Ohio, early intervention services, whatever is appropriate, while you're waiting for the diagnostic evaluation to take place. So this is an example of what the MCHAT-R looks like. One of the other nice things about the revised version, for those of you who might be familiar with the previous one, is that the revised version has some examples for parents, like about the first question about pointing. This has been helpful to be able to clarify so that parents don't misinterpret the question, mark it as a fail, and then it has to be clarified with the follow-up interview. But this is all available online. And there is actually a way that families can do the MCHAT online and then download it or print it and take it to their pediatrician. And all of that is free as well. The MCHAT is also available in multiple languages, which is really important because providers see a number of children from different cultures, different backgrounds, and it's important to screen those children for autism as well as children who are the typical English speakers. The latest CDC study showed that while the overall prevalence of autism is 1 in 68, with 1 in 42 males and 1 in 189 females, the prevalence is different depending on your ethnic background. Non-Hispanic whites were 30% more likely in that study to have a diagnosis of autism spectrum disorder than non-Hispanic blacks. And the differences also were seen with the coexisting conditions such as intellectual disability. 48% of black children with autism spectrum disorder had a coexisting intellectual disability, while only 25% of white children. That suggests that the current diagnostic mechanisms are identifying children differently based on their race and ethnicity, that perhaps children with who are non-Hispanic black children are only being identified with autism if they have a higher rate of intellectual disability or cognitive issues. So there's a lot of concern about health disparities in the diagnosis of autism. The folks out in Minnesota were noticing a different pattern. They were noticing that there were many more children of Somali descent being diagnosed with autism. And so they were curious if the kids from Somalia were at higher risk. So they repeated the CDC study, but just in Minnesota, and found a totally different overall prevalence, 1 in 48, so a higher prevalence across the board, with a 1 in 32 rate for Somali children, slightly higher, slightly less, 1 in 36 for white children, but a much lower prevalence, 1 in 62 for non-Somali black children, and Hispanic children only 1 in 80. All that suggests that there's a lot of differences in the way that people are either screening for or referring or diagnosing kids based on their ethnicity and race. The Minnesota study also looked at the kids with autism spectrum disorder and how many of them had a coexisting intellectual disability, and found an overall percent similar to the CDC study of 33%, but that this varied by your race and ethnicity, that 100% of the kids, the Somali children, were diagnosed as having an intellectual disability versus only 20% of the white children. There are some issues with some of this data based on the percentage of children missing IQ scores, so it may not be that this is truly indicative of the fact of a more severe form of autism amongst the Somali children, but it is very interesting data nonetheless, and it should raise some awareness about the different rates in the different minority populations that all of us deal with. It's important when we're thinking about different ethnic races to think about cultural considerations, because this can make a difference in terms of screening. For example, here in Columbus, we have the second largest Somali population in the United States. And we've done a little bit of outreach with the Somali population and learned some things, as well as going to meet with the folks in Minnesota where they have the largest population. Some of the things that we've learned is that for Somalis, they view causation as it's God's will. So that may change how they even raise concerns to physicians, or even their willingness sometimes for screening. Well, if it's God's will and there's nothing to be done about it, then why bother screening? The Somali language does not even have a word for autism. So there is a lot of misunderstanding and misperception that autism never existed before coming to the United States, for instance. Social norms and the stigma that autism or any developmental concern at all holds in certain cultural communities is really important to realize. If there's a stigma attached to autism or to developmental disability, then it's going to be hard to, it may be hard for family members to bring up concerns about it, or to agree for screening or for early diagnosis and early intervention because they don't want to acknowledge it. So all of these are important considerations depending on what type of population of kids that you all are dealing with. A few words about a positive screen. Again, a positive screen should be an indication for action. So after a positive screen, it's important to refer to Help Me Grow or whatever your birth to 3 services are called in your state. And also important to refer for a diagnostic evaluation. And those two things can be done at the same time. You do not need to wait for the diagnosis before you can get early intervention started. It's also important to think about hearing. One of the wonderful things about the universal newborn hearing screen in most states is that it means that every child's had their hearing screened at birth. However, it also means that sometimes parents, providers say, oh yeah, his hearing was checked. Well, when? Well, there's a lot that can happen from after the newborn hearing screen. So it's important for kids that were worried about with autism or any kind of language delay also have their hearing checked again, even if it was perfectly normal in the newborn screen, because there can be progressive conditions as well as conductive hearing loss that pops up after that time. The diagnostic workup is, I would say, fairly straightforward, but it's not necessarily easy. It involves a very detailed history and physical exam looking for underlying causes or associated conditions, and the use of some sort of standardized tool. The Autism Diagnostic Interview Revised, ADIR, is a very lengthy structured interview that could be used, but it's not used in very many clinical settings. It's more of a research tool. The clinical tool is generally the ADOS, the Autism Diagnostic Observation Schedule. That's a play-based assessment. It does involve some training is needed, some tools, mostly toys, but They're amazingly difficult to replace sometimes. So there's a whole kit that's involved. But it does involve some training and skill, but can be done much more easily in an office visit than the ADIR. And then the other thing that's needed is some sort of assessment of cognition, language, and adaptive skills. You want to be able to tell where this child is functioning at, what their strengths and weaknesses are, and this is useful to be able to guide intervention. The medical workup is very straightforward. Most of the time, the medical workup consists just of a microarray and Fragile X. Microarray looks at all the different chromosomes, while Fragile X is looking at DNA, particularly for Fragile X condition. Those that are sort of the standard of care for looking for genetic conditions. If there's further concern about a specific genetic condition or something else that makes you suspicious that there's something more going on, then targeted referrals to genetics might be indicated. Young children with autism, or even some older ones, may have a tendency to put a lot of things in their mouth, so it's important to check lead level if that hasn't been checked. I've had a couple of kids that did have high lead levels, one high enough to be chelated, so that's really important to look at. Again, if they haven't already had audiology, we'll refer them. Ophthalmology, just to get a baseline, and oftentimes to make sure that if we're seeing any unusual visual behavior, looking closely at objects, looking out of the corner of the eye, squinting, that's not related to a visual deficit. You also want to make sure that kids have good enough vision to be making eye contact, for instance. And only if needed do we generally make a referral for EEG or MRI. Statistics show that about 1/3 of kids with an autism spectrum disorder will at some point in their life have a seizure. But routine EEG monitoring doesn't really help predict who is going to have a seizure and who isn't, and it doesn't help us treat any earlier. That the treatment would still be based on clinical presentations. If I'm hearing a history about staring or unusual episodes, then an EEG might be warranted. MRIs really don't help us. There's not any major structural finding associated with autism for the most part. About 1/3 of the kids do have large heads. If they do have significant macrocephaly, large heads, an additional genetic test, a P10, for the P10 gene is recommended. But just routine large heads doesn't mean that they need an MRI. So MRIs are just ordered if there's some localizing finding on exam that would make us think that there might be something that we need to look at. I want to finish here by just making the case for why we really do screening, and that's for the ability to make an early diagnosis. A recent Cochrane review found that children who received parent-mediated intervention had improved language and interaction. And this was intervention at a young age, so that early intervention age range. Another study looking at best outcomes, optimal outcomes, looked at when children got intervention, how old they were, and what types of intervention, and found that if they got intervention less than 3 years of age, received developmental therapies such as through early intervention and therapies including occupational therapy, that they had better outcomes, that they made more gains than children who didn't get intervention, particularly at those young ages. So that highlights the need for early screening because we don't have a good other way to detect the early signs of autism. And it's important that we diagnose children as early as possible, that we don't wait and see. A recent study from JPEDS this month found that parents of children with autism were more likely to report their physicians giving them reassurance, saying let's wait and see, than even other kids with kids with other developmental disabilities. And unfortunately, this results in later and later diagnosis for autism, and you miss some of the opportunities for that early intervention and for best outcomes. So it's very important to understand that and to do the screening as well as surveillance and watching for the red flags, particularly in high-risk populations. So these are my references, and I will take questions. I think I can. A few more resources here.
Great, thanks so much, Karen. I do have a couple questions that were submitted via the question box. So to those attendees, if you have a question, you can type it into the questions box, or if you'd like to ask over the phone, you can just raise your hand and you'll be unmuted. But thinking back to the Minnesota study and the population there, and thinking about the cultural considerations, we just had a quick question if religion could possibly be included into those cultural considerations as well.
Yeah, that is a great one. Yes, it probably should be. And I think many of us ask about those. We kind of screen for, are there any cultural or religious things that might affect care? But yes, definitely we should consider that.
And then thinking about referral for diagnostic evaluation, just a question about whether or not that ties into the IDEA, the Intellectuals with Disabilities Act.
Yeah, I mean that the physician referral, early identification and referral is early identification is part of the responsibility, if you will, that's sort of outlined as part of the IDEA. So yes, it really does fall under that and should kind of make us think about, yeah, this is part of what we're supposed to be doing, what the law kind of says, because you can't really get accommodations and things if you don't get diagnosis. So that's a good point. Other questions?
I think we might have another question coming in. Just 1 second.
Sure.
So do you expect there to be any kind of follow-up diversity and cultural training for professionals, kind of, I think, related to kind of the cultural considerations around diagnosis and screening?
Yeah.
Or if you're aware of any that are available to folks.
It's certainly one of the things that we've talked about through the ATN, the Autism Treatment Network, a lot. And I think different places are doing different things depending on their population. We are looking at that issue here in Columbus with the Somali population, wanting to look at it also with our African American and our Hispanic population as well. I think Amy Hess is on this call, and Amy, if you want to, she's our Autism Treatment Network site coordinator, but if you want to jump in, Amy, with anything, feel free. So I think there are things that are slowly kind of rolling out, some of them more specific to different locations, but it's certainly worth thinking about some of these considerations and about ways to reach out to those specific populations that are in your particular area.
Hi, Karen. This is Amy. Yeah, we are working really closely with the Somali population here in Columbus to make sure that we do professional training as well as parent training. One of the things that we found is that a lot of professionals are not sure how to do diagnosis, screening, and even ongoing treatment. And getting over some of those cultural hurdles can be really difficult. So we're actually doing a lot of different training with the Somali population, with professionals to help encourage them to continue to provide best care and giving them some best practice tips on how they can do that. And then on the flip side, we're actually working with the families so that we sort of help them understand the best way to engage in care so that they can, ask the questions that might be really tough for them because of their culture, so that they can get really good screenings and then go on to get really good treatment. So we're hitting it from both perspectives because I think it's really important that we build a partnership in care for kids of cultural differences so that everybody's sort of on the same team, and we found that that's been really successful.
One of the things that people talk about is figuring out where are the best places to reach people of different cultural backgrounds. It may not be and often isn't in our clinics. It might be in the local schools, in the local neighborhood. And for the Somalis, for instance, the mosques are a place where they gather, and that has a little bit more acceptance to be there and to talk about things there than necessarily in a doctor's office. One of the other cultural things that when we went and did a kind of a field trip, if you will, to Minnesota, our Somali hosts there were talking about that in the Somali culture, for instance, they want to please the doctor. So they will often say, yes, 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 my child can do this, this, and this, when they can't, because they think that's the right answer. So I think it's important to know those things and to connect with people in the community that can help clarify that. We also heard recently at an ATN meeting about a site that thought that they were going to the right place in the community to have meetings and to have parent support groups, for instance. And the parents said, no, this is a terrible place to go. We would never go there. But they thought that because it was in or near their community, that it was a really good idea. So I think it's important to partner with families. In general, it's important to partner with families, but it's very essential when trying to serve some of these kids from different cultural backgrounds. Other questions, comments?
Yeah, so we have a question about building the MCHAT into a busy routine and how staff members could possibly help with this.
Yeah, I think that's a great question. So there are different ways it could be started. If you have, I guess it depends on your patient population. If you have families that are well-versed in the internet, you could suggest that they go onto the MCHAT.org website and fill it out, download it, bring it in. Some practices have families complete it in the waiting room. It's 20 items, so it can be completed fairly quickly. Some practices do send it out, but I think a lot of folks find that if you mail something out, people either forget to do it. If they don't come, then there's a big price for that. Then deciding who collects it, who scores it, and then kind of seeing how that flow goes. I would suggest doing this as a trial. Oftentimes in the QI world, it's called a Plan, Do, Study, Act, a PDSA. So you say, okay, we're going to try this, Tuesday morning, and we're going to see all the kids of this age. We're going to try doing it this way and map it out. And then Tuesday by lunchtime, you'll have an idea of, did this work, didn't it work? And if it didn't work, then revise it. Don't just abandon it. I think that's what happens a lot of times. People try to implement something across the board, and then it's just, oh, this didn't work at all. And then, it's either back to the drawing board, or it's, oh, we can't do this. And then I think just slowly kind of building it up, getting the flow perfected, and slowly kind of building it up and seeing how it works, and rolling it out to more and more of the kids that are eligible for it is one way to do it.
Great, thank you. So we have another question about autism, specific autism diagnosis centers located in Ohio.
Well, there's certainly Nationwide Children's, Cincinnati Children's, Dayton has autism diagnosis, Akron Children's, and then the Cleveland, the children's hospitals in Cleveland do as well. And there may be something in Toledo. I'm not entirely sure what they've got at the moment. So I think, and one thing for sure is to ask a general pediatrician in the area, whichever area you're from. Ohio also has a program called ADAP, in which some general pediatricians have partnered with the local early intervention services to provide earlier diagnosis. So that's something else that families can look into. But again, your medical home, your primary care physician should have a good sense about what the different resources are locally.
Great, thank you. That's very helpful. Does anyone else have any additional questions that you'd like to ask Dr. Ratliff-Schaub? Those are all the questions that I have.
Okay. Anything else you want to say, Amy, before?
No, just thank you all for attending, and we're always happy to be a resource, even if you're not in our local area, so feel free to contact us anytime.
And I'll just make one kind of final note that CME credit will be available for those attending today's webinar. An email will be sent out tomorrow with a link to the evaluation form, also a PDF of the slides from today's webinar, and a link to a recording of today's webinar. So all of those materials will be there for you to share with colleagues and for you to have for future reference.